Thank you. Thank you very much, Angela, Jonathan, and Haran. So I've been asked, obviously, to give an overview for subcutaneous ICD, the merits and its limitations. Um, First of all, we've seen, obviously, as you know, an evolution in ICD technology, and it's almost as if the ICD has gone full circle from epicardial patches, the transvenous leads, all the way back to now coming out of the heart, the subcutaneous system. As already pointed out, the lead itself is the Achilles heel of the device. We know very well you could obviously deliver ATP, but you still need a lead in the heart to do that. And it's the lead complications of the ICD which are the main issue, which cause a significant problem for our patients. So anything we can do to avoid implanting a lead in the first place it must be an advantage. And of course, with a subcutaneous ICD, we don't have the complications of lead insertion. I can give you data on the worst consequences, as Haran's already shown, with the fidelis lead fracture rate and the uh, the complications that can arise from that in over a relatively short period of time. But even if you look overall at transvenous lead implantation across large populations in registries such as the Dutch, Danish, and French registries, then if you add all the complications up, it can be between about 5 and 10% of lead-related complications, even just at the time of implantation or within a relatively short follow-up period with dislodgement and lead displacement. And now, of course, we're implanting ICDs in younger and younger patients. So the patients are living longer than their lead. So we're not in the days now where we're putting an ICD in a 70-year-old, maybe want it to last 7 to 10 years. We're putting ICDs in 20s, 30s, and 40-year-olds where we need the device to last 20, 30, 40 years because they have well-preserved LV function. And we're implanting a device principally to protect them against VF for example, in the hypertrophic cardiomyopathy population or the inherited arrhythmia population. And also with every time we replace a device, we also run the risk of infection of about 2 to 3%. Now, if you have a transvenous system, that requires extraction with its mortality risk associated with that. While with a subcutaneous system, even with an infection, there's no reported episodes of endocarditis, and the devices are much more easily explanted with minimal risk to the patients. And although Haran's shown you the older data, even if you look at newer data for lead survival, and this is a series from 2020, looking back over about 15 to 20 years, you can see the lead survival is about 15 to 20% at 10 years in terms of complications requiring lead or revision. So we're looking still at a significant attrition rate of transvenous leads. Now, the subcutaneous ICD, of course, is not perfect in terms of its lead design. Originally, we thought we would be able to avoid problems, but of course, engineers being engineers, they tinkered with the lead to try and make it better, in inverted commas, and this resulted in damage to the integration of the ring electrode to the lead body, resulting in a risk of lead fracture, and this has resulted in noise on the lead and inappropriate therapy. The incidence of this is very low, 0.2% of 41 months, but there is a calculated risk of life-threatening harm of 1 in 25. Thanks to trying to improve lead technology, one can run into problems. So essentially, although there are recognized lead complications with this particular model of lead, which is associated with dissociation between the ring electrode and the ring body, and this has resulted in an increase in impedance and noise, with 1 death reported and an estimated risk of life-threatening harm of 1 in 25,000. Now, when one compares this to transvenous leads, or the optimal transvenous lead outcomes as reported for the Boston Scientific leads of less than 0.4% per annum, this risk of lead failure is at least below that reported for best transvenous lead. So it's a recognized problem. The lead has been redesigned, and hopefully these problems can be avoided going forward. So if we take all these problems into account and you assume a 2 to 3% risk of infection, and you have a young patient in their 30s having a device implantation, then you're looking at a risk of infection requiring extraction of about 15%. And if one takes into account the fact that the lead can fracture or lead require replacement, maybe about 15 to 20%, looking at about a 30% risk, 30 to 40% risk of the lead having to be replaced over a lifetime of the patient, and the generator having to be extracted and removed. And so as a result of infection. So it's almost like tossing a coin. You put a transvenous lead in a young patient, you're going to run into problems. It's almost guaranteed to require device replacement and extraction in about 30 to 40% of patients. Now, one of the other issues with the subcutaneous ICD is the risk of inappropriate shocks due to T-wave oversensing. The risk of this originally was about 5% of patients implanted. This has been significantly mitigated now by using a T-wave oversensing algorithm called SmartPass to avoid or minimize this risk of inappropriate shocks. The other advantage, of course, with optimizing sensing is one can also detect silent atrial fibrillation, which is another advantage of being able to monitor patients with an ICD, similar to with transvenous systems. Now, when we look at the risk of inappropriate shocks, this is reduced now to about 2 or 3% as a result of utilizing SmartPass filtering. And this was borne out in the recent Untouched study. On a pooled analysis of an altitude registry, the reduction in inappropriate shocks due to T-wave oversensing was 70%. And this brings the risk of inappropriate shocks into line, theoretically, with transvenous ICD published from Made It Writ. But actually, when this was tested formally in the Untouched registry, you can see the inappropriate shock rate over a period of 18 months to 2 years of follow-up was about, due to T-wave oversensing, was about 2 to 3%. Indeed, this therefore brings the data. When you use a SmartPass filter, you have an inappropriate shock rate of 2.4%, and then this really brings it into line with the best of transvenous sensing technology. Now, on an Italian survey, the main reasons why subcutaneous ICDs aren't implanted is because people fear the need for pacing, such as CRT or transvenous pacing for bradycardia, and also the concern about not being able to deliver ATP for ventricular tachycardia. And one has to remember that we're really implanting these devices for patients who don't have a pacing indication, and also who don't have sustained monomorphic VT. That's a contraindication for subcutaneous ICD technology. And in the EFFORTLESS Registry, where patients were followed up for a median of just under 5 to 5.5 years, you can see here in terms of replacement for pacing, the requirement for pacing was very low, at essentially only 3% of patients requiring replacement for bradycardia pacing or CRT or ATP. This is over a 6-year period. Then when we actually look at complications, the initial complication rates related to inappropriate shocks and device-related complications over 5 years of follow-up, including inappropriate shocks, was 16%, which looks high because initially there were no options for utilizing SmartPass filtering to minimize oversensing, and also the issue of the fact that there's a learning curve associated with device implantation, which is also included in this data. So this is data looking at originally at implantation over 10 years ago on the initial series of patients. So it's not really fully representative of the current era. Now, the most contemporary data comes from the Praetorian trial, which compared transvenous ICD implantation with subcutaneous ICD implantation. And what's interesting here is that we have the true dynamic that's occurring is that despite the fact that the majority of patients didn't have a SmartPass filter, the inappropriate shock rate was higher in subcutaneous versus transvenous, but this was balanced by device and lead related complications with the transvenous ICD. So essentially there's equipoise in terms of the nature of the complications which occur, inappropriate shocks versus lead complications. So essentially overall there was no difference in the complications, but the complications were different. But importantly, in this series, there were no electrode-related failures in this population of just under 1,000 patients that were implanted. And an important lesson was that inappropriate sense episodes predicted inappropriate shocks. And this provides an opportunity to actually program the device to minimize inappropriate shocks. The important thing also is that the shock efficacy was maintained across the series, both for first shock efficacy up to 98% at 5 years, and also for shock efficacy for multiple episodes and for VTVF storm episodes. So we have safety of the device in terms of maintaining shock efficacy over the 5-year follow-up to convert VTVF. So in the last 3 or 4 minutes, I just want to talk about this mentality of fire and forget, that we put a device in and then we want it to be able to do everything, deliver ATP, deliver shocks. But we have this boomerang phenomenon that the more hardware you put into a patient, the more likely this is to come back and bite you. So the question is, do we need ATP in all our patients? And what is actually the burden of ATP that is necessary? And the best data for this comes from a number of studies, including MADE-IT2, MADE-IT-RIT, and also a small study by Clemonti, who looked at a population of patients where he programmed the device simply to deliver shock therapy. And what's been demonstrated is that in this series of patients, if we look at the subcutaneous ICD population, only a small proportion require pacing for bradycardia, with about 1 to 2% per annum, a minimal upgrade to devices I've shown you, to transvenous devices I've shown you for the EFFORTLESS registry. But the issue of utilizing ATP to painlessly terminate VT, if we look at pain-free RX2, which is the data that's usually utilized to demonstrate efficacy of ATP being painless, it is effective, but it's only a very small proportion of the patients were treated. 34% had spontaneous termination. Most of these VTs had a mean duration of about 10 seconds. And so although ATP success is utilized, it was demonstrated in 72%, that was only in 15% of the patients receiving ATP. So therefore, as a result of this, only a small proportion of patients actually require ATP, and many of these VTs self-terminate. And indeed, this is borne out by the MADE-IT-RIT data, which demonstrates the longer you leave the device not to deliver therapy, and the higher the rate you leave it, you minimize inappropriate shock rates, and also you have a reduced mortality. So indeed, with the subcutaneous ICD, because there is a delay in therapy of about 20 seconds, one is allowing many of the VT episodes to self-terminate that wouldn't be treated. So what about no ATP at all with a transvenous device? Well, we know from the Clemonti data that he looked at a population of patients where he programmed simply a VF zone of 220 with monitoring between 170 and 220. And in that data set, there are only a small number of patients actually received shocks for the higher rates, which I'll show you in this slide, or magnify it up. So this is over 200 patients. 2% of patients had an episode of VT that was sustained. Only a small number are actually pre-syncopal. One was syncopal, and one patient, 11% of patients had an appropriate shock, and 7% had an inappropriate shock. So even though there were some slower VTs, this didn't result in any significant compromise and any events where they had VF and they didn't receive therapy or had a delay in therapy resulting in a complication for them. So, and indeed, if you do the maths on this, when you draw the line from MADE-IT-RIT, you have a lot of termination, episodes of VT-VF terminating, as we've shown here with the subcutaneous ICD, about up to 10% of episodes self-terminate, which wouldn't necessarily require therapy. And indeed, the rate of shocks is the same for the subcutaneous ICD as it is with transvenous ICDs. So although ATP is there with the transvenous ICDs, it's not necessarily resulting in a reduction in overall shock rates. And indeed, if we look at monomorphic VT episodes of the subcutaneous ICD, the annualized rate of potential shocks that could have been avoided is 1.1% in the subcutaneous ICD population. And indeed, if you do the maths of the Clemonti study, you would avoid basically over an 8-year follow-up period, just on 0.3% of patients per annum, or 3,000 patients per annum, 3,100 patients per annum would have benefited from ATP in that study. So a very small number in that population programmed simply for high rate shocks. So one of the problems with the SICD, of course, is that often we need a GA. This can be minimized now using truncal blocks to undertake the procedure on the local anesthetic. And ideally, what we want to be able to do is not to undertake a DFT at all. This can be avoided by actually placing the device in a more lateral position, posterior to the mid-axillary line. This essentially means that you can sandwich the heart between the lead and the generator with minimal fat under the coil. And by doing this, one actually can achieve very low DFTs. And indeed, the Praetorian trial is now being undertaken to look at ICD positioning to minimize to demonstrate that you can position the device without delivering a shock at induction. And this is the Praetorian score, which allows you to assess the device position. And in this study, the investigators placed the device posteriorly and in the optimal position behind the mid-axillary line, and also with minimal subcoil fat, and demonstrated if you didn't perform a DFT, first shot efficacy in real life was equivalent to if a DFT had been performed. So I think with the right evidence, we can move away from doing DFTs for subcutaneous ICD implantation. And of course, now we have leadless pacing as an exit strategy for bradycardia. And I expect over the next 10 years, we're going to move into a phase of using leadless pacing in combination with subcutaneous ICD, both not only for right ventricular pacing and right atrial pacing for bradycardia, but also for resynchronization. And indeed, the advantage of a leadless system, if you don't ablate your patient monomorphic VT, is that you can deliver ATP. And this will be possible with a combined system. So to summarize, the subcutaneous ICD has the advantages that it's safe and effective in terms of terminating ventricular arrhythmia. There's no risk of hemopneumothorax and lead complications essentially insignificant without the risk of lead extraction complications. And there's no risk of endocarditis of subcutaneous ICD with an infection. The main disadvantages remain the fact that you need a GA for implantation. And of course, there is still this risk of inappropriate shocks, which can be mitigated with optimal filtering. Really what we need is the longer term outcomes of transvenous lead technology versus subcutaneous ICD to make final conclusions about the comparison, hence the extension of the Praetorian trial. Thank you for your attention.